Vitrectomy for retinal detachment in children, again, is a challenge. We all know that the vitreous structure in children may be a bit different from adults. It is simply well formed, and this implies that the posterior hyaloid is fairly adherent to the underlying retina. And this may pose a serious challenge for a surgeon who is managing this case, especially that hyaloidal remnants in children may be aggressive enough to result in a vicious circle of recurrent PVR and a very grave prognosis. Definitely, scleral buckling still is the first option, and we opt for this, but this is not usual. This is not for all cases, and in some cases we still have to challenge the hyaloid. And when we are back to the review of the pathophysiology of retinal detachment, we have to face it. There is a vitreoretinal traction that needs to be relieved. And we need to focus on this. The first step is to detach the posterior hyaloid, and we have several tools in this. In all the cases, we pull on the posterior hyaloid. We use a probe. We may use the magical instrument, the Thanos scraper, which plays a great deal of benefit in this concern. We may have a sharp instrument that helps us to pull on the posterior hyaloid, sometimes a combined mechanism of active suction with the sharp instrument. But in all these cases, it is a pull on the posterior hyaloid. There is no problem with that, but there is a limit. How far anteriorly can we go with the posterior hyaloid so that we reach the vitreous base, the level of the vitreous base, without the risk of jeopardizing the IOL capsular or the lens diaphragm if a lens-sparing vitrectomy is performed. And even though the instruments like the Thanos scraper may help us a lot in managing, but it is not, I remind you again, it is not about the initial step in managing the posterior hyaloid. It is about how far peripheral can we go and how far can we end up without leaving sufficient hyaloidal remnants. So this was the idea that I started to think, why not to push on the retina, starting from the equator to the periphery, so that I can finish up the hyaloidal detachment without insulting the IOL diaphragm. I had about 26 eyes. The technique is, I start in the usual fashion, but the triamcinolone is mandatory in these cases. And I pull on the posterior hyaloid first till the level of the equator, and then I start to switch my technique. In this way, I have to hold the posterior hyaloid and stabilize, and to push with the other hand on the retina so that I can separate the two structures from each other. Holding the posterior hyaloid can be done with either a forceps, an end-gripping forceps, or the vitreous probe itself at times. And the retinal push may be performed with either a Thanos scraper or sometimes the vitreous probe itself, but with the port facing away from the retina. I had a primary reattachment rate in the cases 88.5%, which I find nice, and a secondary reattachment up to 96% in the cases. Iatrogenic breaks happened in only 2 cases out of 26, and this was for me satisfactory, but there has been a hemorrhage around the breaks in 3 cases. Still, again, the advantage is that we can detach and separate the both structures without having much iatrogenic breaks. But this entails some tricks. It is better to use the Thanos scraper to do the whole maneuver in a as slow as possible so that you wouldn't be aggressive on the retina, and at the same time make the push at the intersection between the posterior hyaloid and the retina. Because if you go posteriorly from that level, you are liable to have iatrogenic retinal breaks and hemorrhages. In this case, I'm here elaborating again the technique, and the slow maneuver is still a striking point in this maneuver. Usually the inferior retina is easier to manage than the superior retina in these cases, which is actually, it is not a disadvantage in my point of view, because this is the really serious part of the retina that needs proper management. And as you see here, the Thanoscraper is my first choice usually. I may use the probe only in case the Thanoscraper is weak enough to push on these.
Could you wrap up
sometimes
now?
I have limitation when there is a focal area of PVR, an early grade C PVR in the periphery of the retina, but I usually finish up in a satisfactory way. So I suggest that retinal push may enable a complete detachment of the posterior hyaloid as far as the vitreous space, and this may result in a favorable outcome in pediatric cases. Thank you so much.
Thank you very much.
In your first talk, you mentioned that you're using liquid perfluorocarbon. I have a trick. I rarely use liquid perfluorocarbon in simple retinal detachment cases. For example, I do it if they have a break, I do an active suction through the break with air fluid exchange. I turn the head toward the retinal break, and I try not to use liquid perfluorocarbon. When we look at the American Retina Society practice and preferences, they use less liquid perfluorocarbon. I try not to use it very much in very rare cases, and also I don't agree with under air vitrectomy. The vision is very difficult to do, and I used it in 2 or 3 cases. I'm not going to try to use it again, the under air vitrectomy. It's very difficult, and I didn't find any advantages of this.
Well, I agree with you that we all look forward to reducing the use of perfluorocarbon, but in so many cases, the break may be peripheral enough that even the tilting may not make you feel satisfied with a completely dry posterior retina to that level. The second point concerning the visualization under vitrectomy, I remind you that I'm using the chandelier illumination, not the fiber optic. The chandelier is trapped at the entry, and it provides a typical wide field view with less glare. And the second point is that the self-indentation that I perform, as was demonstrated clearly in the videos, brings everything to your view with almost very few glare, except in the inferior part around. It may be difficult when you work under the fiber optic light, but with the chandelier, it's totally different. Thank you.
Thank you very much. Another question?
It's only a very short comment. I've seen different surgeons doing different things with different biome systems, and there's a big difference in the illumination, especially under air. Some were useless, some were as under liquid, and the best I've seen was a size resight, and I do not have stock in size.
That's true, there's a big difference. And the best is even with a contact lens on the eye. But anyway, thank you very much.